Yes,
Hello.
thank you very much. Thank you. Welcome everyone to this second case conference on palliative care in Ukraine, and we are happy to have an excellent set of experts to help us today in the conduct of this case conference. We also are introducing a slight change or a significant change in the format of these case conferences to introduce controversial topics that we face in palliative care. And this will really actually be quite helpful to the field as a whole. We had added severe injuries to the need for palliative care several years ago with the publication of the Lancet Commission report on access to to palliative care and pain relief. And but really, many palliative care providers lack clear guidelines about how to care for patients with severe injuries, though the American College of Surgeons has developed guidelines and some trauma societies have done so. So it is acceptable that we consider palliative care for people whose injuries are severe enough that they could be life-threatening. Today we have with us, I'm happy to say, several experts beside myself. Am the executive director of the Worldwide Hospice Palliative Care Alliance, but I've been working for almost 50 years working in palliative care in the US, but also in many countries around the world. And I'm licensed as a clinical psychologist, and I'm actually trained in neuropsychology, so neuropsycho testing. So I have had some experience working with injured patients. Dr. Marcin Chiswick is the professor at Fox Chase Cancer Center, Department of Hematology and Medical Oncology, and Director of Supportive Oncology and Palliative Care. He is one of our leading experts in the U.S. in palliative care and is also from Poland originally. The Director of the American Eurasian Cancer Alliance, my colleague, Dr. Sophia Michelson, is with us, as is Dr. James Jackson from Massachusetts General Hospital and Harvard Medical School, who also has quite a bit of experience working in the Eurasia region. He's done some fellowship training in the region in Central Asia. Dr. Tom Smith, unfortunately, is not going to be with us today, but we look forward to him participating in future conferences. So with that, I would like to turn it back over to you, Alexander, to introduce just the clinical staff who will be presenting the case today. Thank you all very much for coming.
Ем, По-перше, я хотів би
First
знову
of
ж
all, I
таки
just really like to say
нашим
thank you to our
американським колегам, з
US
якими ми вже
colleagues
вдруге
that we are meeting for the second time here, and we are discussing the really precise and specific clinical cases. And also, we are hoping that this tradition would be continuing because we think and we consider it is useful. Here we have on the call,
Я бачу
as I can see,
приблизно
around 70-ish
приблизно
house
50
facility. So like 50
оскільки
house facility and some individual people as well, since we have, so it's under one connection. There's also like a few people because they're sitting just in the audience where are listening. And as you can see in some of the pictures, there's also a few people sitting there. So there's at least like out of 77 regions or oblasts of Ukraine. So it's sort of like states, but not as big. So the participants of our conference, all of them are representing medical facilities, healthcare facilities, where most of those health facilities and doctors are present here. They're dealing with both the palliative care and also rehabilitation. And as of today, we're going to have a really interesting case definition and case collection that Svetlana Pasik will present on the palliative care for people with the really complex trauma and polytrauma for people that receive that in the military area or military action. I'm afraid of being wrong with all of the positions that you are taking and titles. So I will just pass the floor to Svetlana for her to present herself. So I can just only say that together with Svetlana, we know, and with this Department of Palliative Care where she's working, we've been familiar with for a number of years, I guess more than 15 years. And I can recommend this department, this or whole organization, their health facility, as one of the leading in Ukraine in terms of palliative care and the one that's at their own real place that really dealing with the honestly, correctly, and with all the matters of palliative care according to the international standards. I would just like to pass the floor to Svetlana Bazik. And then after, if you can get back the floor to me so that I just say two words for the organizational purposes. Thank you so much. And Svetlana, the floor is yours. Thank you so much for such a high praise. My name is Svetlana Bazik, and I am the head of the Palliative Center and Care Provision of Cherkasy Regional Hospital, which is Tier 3 hospital. And so thank you so much for adding me to such a wonderful opportunity to discuss really complex case definition and so cases presentation. And I really hope for fruitful cooperation now and in the future. And if possible, thank you, Svetlana. I would like to say a few words just specifically from the organizational purposes. The first one is that we have officially we are working till 5 o'clock Ukrainian time, but we can stay for 5 minutes longer or something. So therefore, if we will finish like 5:05, and if the process will go in that way, it's not an issue if we extend our stay for a few minutes because the technical support can provide for that. But of course, we are planning to work and finish on time. The second matter, I would really ask for all the participants for the active participation. We're gonna have like not a big, but still it's a presentation really fast, but also from all of you, dear clinical psychologists, dear doctors, dear organizers of palliative care, we will be waiting from you of your opinion on this case. Like, what could you have been done for this person, like that we will be discussing? And so, to that person, and also like the question right now, I would just like to all of you ask to turn on your cameras, as I did it, and also for other participants to turn it on. We will do like a small picture and a screenshot because this is needed for the presentation. Great, thank you so much. And later on, we would be able to turn it off. Great. I just did a screenshot. I guess this is, you can turn your cameras off if you're willing to do that.
Ну, я думаю, ми будемо починати, так?
So I guess that we can start since the picture was made and everything is going well. I just did a screenshot and a picture, so yeah, I guess we're good to go. Because we don't have that much time. So yet again, I will try to go in as short as possible about the plethora of patients that are reaching out to us and merging them into sort of one case. And this year specifically, during the first 2 years of war, of course, those patients have been really plentiful, but they were reaching out into the treatment departments and rehabilitation department, not palliative department. About the up-to-dateness, you've seen the presentation, and I just don't like to stop based upon. I just like to say about the really representative case that are happening frequently in the beginning of summer. A charitable organization approached us that in the somatic departments and the rehabilitation, they have like a really complex trauma ex-soldier that they could not receive any more treatment and finish his active treatment and finish his rehabilitation. So they have an issue, like the patients still have really complex diagnosis, and you can see the diagnosis in the presentation, which is complex head trauma, internal organ trauma, and also the thoracic trauma, neurological issues. If you can you go to the clinical case for the diagnosis of the patient? This is slide number 5 to be specific.
Там, де власне, так.
Great. This is the slide. So the second part of the slide, this is just his diagnosis. And they are in the format of A4 or just a regular paper. They took half of the paper. So this is just the concise version. And so regarding the functional status of the patient has been, and so the second half of the diagnosis, patient did not move very well. He had hemiparesis, and on the left side, he could not, he felt a constant pain that we started to try to compensate with non-narcotic analgesia. Then they just give him pregabalin, was a recommendation of psychotherapist, and so then the patient had a cognitive decline. He could not know like where he is, like what the day is, or what is the location that he's at. Like he's not responsive to his injuries. He was really suppressed. He worked with the psychotherapist for like a really long time, and then they consulted by a psychiatrist, with a somatic doctors, or by somatic doctor she means like internists and like trauma doctor and all that. So anybody who's doing something with the body. And so because of those doctors, we could somatically stabilize him. And also for a month and a half, they've been in a rehabilitation department. He was working with psychotherapists and with the rehabilitologist or physical therapist essentially. So to find a point of how to be self-sufficient, because at the beginning of summer, when we just have this organization reaching out to us, charitable organization, we just only spoke about like just the hospice stay, not a treatment, just the hospice stay of those complex trauma. So just because this person did not have like whoever who could pick him up. Like he only had like a ex-wife who did not want to take him in and take care of him. We did work together with the team of this inpatient part of the hospital. We worked with their psychotherapist and our psychologist work. Our social worker worked with them. And so also family therapy from months and a half. And we faced that the ex-wife has actually been, we first thought about the palliative care inpatient, but taking into account his emotional status, we just are trying to have him out in outpatient department. We are just visiting him and his place of residence once a week, and 2 times a week at least we are getting in contact with him. Before we did this much more frequently because the patient had like, he was on oxygen constantly. He was on oxygenation, and so now he's fully self-sufficient in terms of breathing. His vitals are okay, and he has an improvement in his so like movements are finally better. So after the antidepressant that he's taking for months and a half, he's emotionally more stable, and he doesn't have this much pain but still pain is really in the high scores. And then in the discussion there have been a question like what can we help him as the pain relief for him, because on the pain scale he takes 6 out of 10, even though he has medication, NSAIDs are in, and non-narcotic analgesia as well there, and also pregabalin is there, but like an antidepressants are there, still it's not helping. And so it's mental state, which is the beginning of summer, that we see that he has a cognitive decline in neurocognitive disorders, and also PTSD results, and also PTSD signs that he also hadn't possessed, unfortunately. He had flashbacks, he had been on the war, and also those complaints are still there. And we were able to just relieve it to a point, but we don't have like a significant progression as we would have wanted to have for this patient. Patient is not interested in his recovery. He is really pessimistic. He's not there, but still passively he knows that he has some improvements of his regular state. If we can have next slide, please. And so if shortly I was trying to describe this patient, to just point the attention to the request that we have at this moment of time from the patient. And if there is a question, I would just like to go on the specific case, or like maybe somebody needs an additional data or initial data if we can. this is the time when you can ask questions about the initial data of the patient, even if something not clear about the
Бо
patient
люди можуть
before I move
учасники
on.
писати
I mean, the participants can always go
чаті,
down and
так?
text
Зараз
in
я
the chat,
перегляну.
інженер і я, ми його
and both me and the
читаємо.
technical support, we are looking at it so
Поки
that
що я
we
не
are
бачу
following
питань. Я
through. I
думаю,
don't see
що
questions right
досить
now.
багато людей вже
I just think that a lot of people have
ознайомилися з самою
familiarized
презентацією,
themselves with the
самим
presentation
описом.
itself and with the case presentation.
Не бачу я
So
поки
I
що питань
don't
по
see
самому
any
випадку,
questions on the
які
case
у нас
itself. So
виникли на
what
даний
kind
момент
of
проблеми, які би нам хотілося
issues
обговорити з колегами.
would we like to discuss with the
Перше, що
colleagues?
заважає людині
First,
функціонувати
of what
нормально
is
на даний
obstructing the
момент,
person,
це
not allowing
болевий
him to
синдром.
function, which is the pain,
З
significant pain
соматичного
syndrome. With
стаціонару
the
і
somatic
продовжував
things,
реабілітацію, він отримував золпадеїн.
they started to get sulpadiene or others, and so
Уже після того,
from
як
the
ми,
other things. And so
скажімо,
when
зв'язалися
we
із
got together and
психіатром,
in
який
touch
його
with a
консультував,
psychiatrist that been consulting
психотерапевтом,
him,
з ним
with a
працював,
psychotherapist that
додатково була
worked with him,
призначена габалін,
and we
прегабалін,
also he given him pregabalin,
75 мг,
75
дійшло до
milligrams, and so we got to
150 мг.
115
Ну,
milligrams.
ефекту особливого не
But
було.
we did not
Додатково
have a
призначили
relief because of that.
30
We have
мг,
duloxetine for 30 milligrams, and we got it to 60
Стан
milligrams.
дещо
His
покращився в
state of
плані
health sort of
больового
has
синдрому,
improved
але
regarding the
він
pain syndrome, but it's still staying
досить
like
виснажливим для пацієнта. І
really
перше, що
exhaustive for the
починається
patient.
наша
Like
розмова,
it's
це
constantly exhausted, and he's
з
always
болю.
saying that he is in so much
Також у нас
pain.
не
And they
скажімо,
also
залишилися проблеми з
we
із
only have
сном.
like issues with his
Пробували так само,
sleep.
коли він ще перебував в
And when he was in the
стаціонарі
somatic
в
department or
реабілітації,
inpatient
кведіапін.
parts of the hospital, he got quetiapine.
Препарат
And
працював
so
буквально
it was
день-два,
working for
далі
like a
він
few days,
перестав
then later on it
працювати,
just stopped
і
working,
пацієнт
and the
відмовився
patient
взагалі від
said
прийому
no
снодійних.
to take
Хоча
any
він
kind of
далі
sleep
наголошує
medication,
те,
even
що
though
є
he's still
проблеми
saying
зі
that he
сном, але
has
він
issues
це
with sleep,
переживає
but
як
he's just
свій
going through this as just
Він не дуже схильний
he's not really
його
inclined
обговорювати,
to
він і досі працює з
discussing that.
психологом,
He's still
але з
working with a
психологом
psychologist, but a
працює,
psychologist he's working
пасивно,
um
тільки через те,
like
що
passively
наполягає,
just
скажімо,
because
дружина на цьому.
his
Самостійно
ex-wife
він
is still
досі,
pressing to
ми
have
з ним
that.
працюємо
Really,
вже
we are working
фактично
with him
п'ятий
for
місяць,
5 months,
він не
and
хоче
so
про це
for 5 months he
розмовляти.
doesn't
Він
want to
це
speak about
мотивує
the
тим, що
issues
ви
with
нам
his
це
sleep.
не
He motivates
довіряєте,
this.
що ми там
You can't
пережили,
even
що ви
imagine
нам
what I've been
можете
through.
нам
You
це
can't
сказати.
really help me with that. Like there's nobody who can help me with that.
Ну і плюс
And
функціонування
also, like his
покращується.
functioning has been
Єдине, в чому
improved, and
успіхи
the only
є,
thing that
те,
we
що ми
have
працюємо,
success
скажімо,
is
з
that we are
реабілітологами,
working
і
with the
покращується
physical therapist,
його,
and so he's improving in
скажімо,
his
функціонування
functioning and overall
технічне.
states of
Рука,
like so
нога.
he can finally
Він
move,
почав
his hands and feet can
виходити
move.
на
He started to
вулицю.
go out to the
Звичайно, не
streets.
спілкується, але хоча б
He's not
виходить,
like speaking
дихає
with
свіжим
anybody, but
повітрям,
at least he's
цю
having some air.
активність він
So he's catching some fresh
демонструє.
air, and he's
Рухову,
somewhat
скажімо,
at
більш
least
соціально.
physically functional,
І
but
ми
he's not yet
розуміємо, що це
socially functioning.
людина,
And we know that
якій
this
40
person that
років,
is like
і в
40
неї
years of
ще
age, and
попереду багато
he has a lot of
життя.
years to
Тому було
come
би цікаво,
usually. So we would be interested
можливо, в
in
когось є досвід,
maybe
хтось
somebody
працює
has an
вже з
experience, or somebody's
психологом,
working
більш,
with the military
можливо,
personnel,
успішні
or
кейси,
maybe there
можливо,
are
в
some
кого є
successful
якісь
cases, or
рішення
somebody has like some
ефективні щодо
solutions,
роботи з такими
active. Like,
пацієнтами.
what do you do with such patients? Like, we would be really interested in that part. Stephen, if you're speaking, your microphone is off.
Колеги тільки відписуються, що вони
Sorry, Dr.
працюють.
Svetlana, thank you very much.
Переклад.
Sorry. This raises a lot of, this is a very challenging case, and sounds like you've been doing an able job of helping to try to address his issues. We could make a number of suggestions for his treatment, and I'm wondering if Dr. Jackson or Dr. Marson have any suggestions about his pain management, which I think is a complicated issue since he's not the typical patient in a terminal condition where we have very little hesitation about giving opioids if there is significant pain. But But in his case, he may in fact need stronger pain medication, but I think we need to, kind of look at the burdens and benefits, if you will, of increasing his analgesic treatment. Do you have any comments on that? And then I'll bring in some suggestions around the treatment of his PTSD and other suggestions.
Good morning, everyone. Dobry dzień. It is as you had said, Stephen, incredibly challenging case, and I commend you all for taking a wonderful care of him, because it seems like despite the obstacles you have made a lot of progress already, and I think this is something that Ukraine is now faced with, and many of the soldiers will need help. So I think it's a very important thing to think, and I'd certainly palliative care principles that are based on interdisciplinary care and involvement of multiple specialists, and really paying attention to the whole person with the psychosocial, spiritual aspects, I think are incredibly critical. I think that before I have some suggestions about specific things, but before I go there, I just wanted to highlight the fact that I think, that sort of the concepts of total pain is really very applicable here, because he clearly, what I heard you say is that he did say things about like, no one can help me, and I'm in this sort of, I think you even said total pain, like involving his entire body, and clearly he has a lot of somatic and nociceptive injuries that could cause pain, but I also think there's a lot of suffering and existential suffering that need to be addressed, as well as we are optimizing his treatment regimen. So I think it's incredibly challenging. I was actually, in fact, before that conference, I was trying to look up any American-based publications about trauma and taking care of trauma patients from combat wounds, and I think. And I never worked at veteran administration hospitals, but there is a concept of polytrauma systems of care, and I was able to find one reference to it, and I'll put it in the chat. What I think the VA hospitals have organized care for soldiers coming back primarily after the Afghanistan and Iraq wars. So that might be something to look into to see, how those kind of a systems of care function. But specifically for this case, I think the question about pain is incredibly important, and I completely agree with your initial approaches with using the non-opioid analgesics, including acetaminophen, pregabalin, and duloxetine. I think those are all great choices that sort of address the neuropathic aspects, but also the potential depression and anxiety in this patient. I think the pregabalin can still be titrated if tolerated. Of course, at higher doses, it can cause sedation and other issues, so it may not be appropriate. But if there's a room for gradual titration, you can try to go higher on pregabalin. In some of our cancer patients, I use several hundred milligrams a day if tolerated. When it comes to the stronger pain medicines, this is something that we also are actually dealing with in cancer survivors, which is a little, not exactly the same situation, of course, but a similar issue where one faces potential pain treatment for the rest of their lives due to the injuries. And nowadays, we know a lot more about long-term effects of opioids, and they are not benign, and I think have to be taken into consideration. The hormonal imbalances, the effects on immune function, and the risk of development of addiction or substance use as a result of being exposed to opioids for extended period of time. I think those risks are there and need to be acknowledged. At the same time, I do feel like this patient does require, at least now, stronger pain medicines. One that I would consider strongly, probably my first choice would be buprenorphine. I'm not sure if buprenorphine is available in Ukraine, but I think in Europe there is a transdermal buprenorphine, which I think would be ideal for this patient. Buprenorphine has a lot of distinct pharmacological characteristics that make it different from traditional opioids. It causes less tolerance. It causes less of other typical side effects associated with opioids. I think it's easy to administer when the patches are at least the ones we have in the US are 7-day weekly patches. I think that's usually very well tolerated medication with less constipation. I think it could be a very useful medication to add on to his regimen and then titrate depending on the response. And I think like with anything in those kind of situations, just sort of the trial approach, when you try something, you add it on, you see how the patient reacts, and then you either adjust the dose or discontinue if there are side effects that you'd use. But I think trying it would be very helpful. I know there's a lot to talk about, so I'll stop right now, but I'll put in the chat the reference to the article I mentioned. And then thank you.
Excellent. Thank you, Morrison. James, any comment to add?
Yeah, I was just thinking of both those exact things, which are trying to first, sort of hone in on a formulation of this patient to understand, what are the dimensions of total pain that there are. And I think that's the interdisciplinary approach that you all have been working very admirably on. I think even, something that in every system, the interdisciplinary approach, I think is a challenging one. But it sounds like in this patient's case, you've done an incredible job on that front to support them with the physical pain and rehabilitation piece, the psychological pain, the social pain, and the spiritual pain. I think then it sounds tricky that the next step that I might think of after trying to kind of formulate a patient's diagnosis and what aspects of pain they're suffering from is to then align on, what symptoms or what goals of symptom management you can come to. So if he feels like, it's hopeless or helpless to try to help with sleep, then I think it's going to be very difficult to help with sleep. And if he feels that it's hopeless or helpless to help with pain, I think it's going to feel very difficult to help with pain. So maybe by, trying to align on and normalize, what veterans go through after traumatic brain injury, dealing with PTSD, how normal the sleep disturbance is, some psychoeducation about how important it is to address sleep and try to just align together on some things that they'd be willing to try, might be, a way of also trying to prevent what so often I see happening in these situations, which is provider burnout, because I think it's really difficult when you have patients who are just, you want to help and you want to help and you want to help, but there's not something that they're willing to align on and to try. And then as far as the management of physical pain, I was absolutely going to say also buprenorphine would be a great first choice. And if buprenorphine weren't available, then perhaps the lowest dose of methadone, maybe something else to consider, just depending on formulary, availability. Yeah.
Thank you very much. I'm not sure about methadone is in many of the former Soviet countries not available, but we defer to you locally in terms of whether it's available or not, and same with buprenorphine. It is available generally for treatment of opioid use disorder, but not for pain or for treatment of physical symptoms. Let me make a few comments about this case, and thank you, Dr. Teswick, for your suggestion about the VA system's polytrauma treatment program. I think one of the things, part of the context here is that in Ukraine is attempting to create one of the first psychiatric palliative care facilities. And this is quite admirable that you're, interested in doing this. And in those in the population that you're intending to care for, where the needs are enormous, we typically would see that the patients, you kind of first have to deal with the trauma issues that the patient's experiencing oftentimes, we find, and probably the majority of these patients at least are going to be experiencing symptoms of post-traumatic stress disorder. And in the case report, you've described him complaining of symptoms of PTSD. So you might want to make sure that staff that are working there get some additional training in some of the techniques that are recommended. Actually, there are 4 techniques that are strongly recommended for PTSD. There are various, combinations of cognitive behavioral therapy, traditional cognitive behavioral therapy and cognitive processing therapy, as well as prolonged exposure treatment. Those are 4 recommended treatments for PTSD that have good evidence base behind them. There are additional ones that are conditionally recommended, and those include medication, eclectic psychotherapy, but also movement desensitization and reprocessing, which has gotten a lot of attention in the veterans community, and but requires some specialized training. Each of these approaches would require some specialized training. Some may have been trained in that, and that may already be available, but we recommend that you use those approaches first if you can. We also heard, as Dr. Marson said, some suggestions the patient's depressed. He is getting antidepressant treatment, but the combination of psychotherapy and medication in depression is generally thought to be the better outcome than either medication or therapy alone. If there are existential aspects to this, we see this a lot in palliative care, that people have a sense that they have lost their meaning in life, or haven't quite discovered what their meaning is. And so there's a number of sort of narrative therapies that can be used for helping people create a kind of coherent narrative to their life and to the situation that they're in. I think in addition to the polytrauma treatment that was referenced, he may benefit if you could, and he may actually become someone who could help others in their facing trauma. And it's an enormous and growing population of war injured patients, and that sort of mutual support of other veterans who've been through trauma and have been able to adjust and find ways of coping, new ways of coping with their disabilities and their limitations. So keep that in mind as something going forward, whether there's an opportunity to begin to develop peer support systems for the patients in your unit as you get more patients. It's a little unclear, whether he's had a full neuropsychological assessment and workup, but I think that would be quite valuable to really get a sense of where his deficits are and where his strengths are going forward. If that can be arranged through your unit, I think you'd probably want to have someone competent in neuropsychological assessment available to help you in the unit. I think that'd be a key and probably frequently needed service. And in terms of his therapy, there was relaxation training mentioned, and that of course is helpful, but is not as targeted as some of the PTSD treatments we discussed. You might, but it may be helpful for his sleep disorder, though that's a whole nother area that would need to be unpacked as to whether that's due to his pain syndrome or his agitated, his depression and psychological state. Anyway, those are some some thoughts and recommendations thinking about this going forward. I think we'd really like to hear from the clinicians that are all out there listening to us today, and to share any of their experiences that they've had, successful or unsuccessful, as well as any questions that you might have. So back over to you, Alexander, and we can maybe try to vet the questions that, if there are questions in the chat or Q&A.
Ага.
So,
Вибачте, я два слова скажу.
I would just
Тут
like to
є
say a
в
few
чаті
words. We have in
дуже
chat like a
цікава,
few of interesting
пропозиція
proposals.
Анни Проценко. Вона
Like
каже,
Anna
що психолог,
Procенko,
на
she
жаль,
is a clinical
не
psychologist.
працює в
She
неї
unfortunately
мікрофон,
she doesn't have a
але
microphone
я
functioning,
зараз
but
просто
let me read
зачитаю,
out the
чи
proposal that she had,
шановний перекладач сам
or the
зачитає.
interpreter can read it out for you because it's there somewhere on top of that. So what she
На
says
правах
is on the rights
клінічного
of the clinical
психолога,
psychologist or
патопсихологічне та
pedopsychological and
нейропсихологічне повне
neuropsychological full
обстеження
examination.
проводила б
I would do so also in
психокорекцію,
psychocorrection line of work. And also
проводила
I would do the line of work on the recovery of his
психоемоційного
psycho-emotional
стану,
status, overall and specific ones if he has
роботу
issues.
б
I would do the line of work on his
стабілізації,
stabilization, so that he's at
прийняття
least stable in
себе
where he
тут
is, and
і
his
зараз.
self-acceptance in here and now for him to
Потім
get
вона
there.
пише,
And then she's
Анна
writing that
Проценко,
the,
клінічний психолог, пише,
again,
що
from Anna Prochenko,
робота
she's
з
saying that the working
ресурсом
with his internal resources,
обов'язково
you need
пояснити,
to
що
explain to
те,
the
що з ним
person
в
like what
емоційному
is him
стані
happening to him
відбувається,
and
що
his
це
emotional
реакція
status,
на
that this is
перенесений
just a
досвід
response
війни. І
to
що
the
з
experience
цим
of
можна
war and what
зробити.
can be done with that from an
І
examples of other people. And
далі
also later on,
Анна
also Anna
пише,
Prochenko is
що
mentioning that
хороша дуже
the
тема,
peer-to-peer topic
рівний
is really
рівну.
great.
Ця тема
It's
дуже
really
дієва
acting and
та
it's the only thing
мотивуюча.
probably that's motivating for in
Це я
cases like
просто
that.
прочитав,
This
тому
is I'm
що в
just
неї
reading out
мікрофон
because
не
her
працює.
microphone unfortunately is not functioning.
Але є і
But
інші
there
теж
are others as well who had
думки.
mentioning and other opinions that have been done. So
Чи чути мене?
can you hear me okay? Was everything put through?
Yes,
Чутно
yes,
абсолютно.
yes, we can hear you fine. I
Uh-huh.
just will make one other comment. And thank you to the psychologist for bringing up those issues. It sounds like they're aware of some of the things that can be done to help this population of patients. And we're not just talking about this case. I think we want to talk about the potential, future patients coming. But we also want to be sure we address the social dimension and, whether we're not obviously knowledgeable about how these cases are handled in Ukraine, but I would normally assume that there's some pension or disability benefits that would be available to the former military to help them be transition to independent living at some point if they're physically able to do so. But just to mention that, and let's go back to Dr. Svetlana. Do you have any response to the questions that have come about?
Ну, я хотіла би зазначити з приводу
I would just like to mention regarding medication, buprenorphine and methadone are used only for the opioid substitution therapy, and they're not used for the pain syndrome. We can't legally use them or easily legally use them. We can't do that. Regarding the mental health support, what we're doing and just our specialist is doing for a lot of many months. And so during the previous months, he did so when he did the somatic treatment before and rehabilitation, the psychotherapist and the psychiatrist as well. They're really interesting opinions. The only thing that I have, and so I had like a feeling that maybe in Ukraine we need to create like an interactive community of specialists in palliative care and psychologists, psychotherapists, where they would be able to daily like exchange opinions and topics and to just find the experience that is lacking and that is still present in the specialists in Ukraine.
Great.
Я бачу тут іще кілька
I
коментарів.
can see that there are a few other comments here. Let me, because probably people don't have the microphones on, or because they're just short. If Ludmila's, if you can say a few words to elaborate more in your comment, and can you turn on your microphone because you texted something and it's not really clear, and maybe not everybody understands. And also, I would ask for Hanna Misko if she is able to turn on her microphone, and Natalia Koval to also say a few words. So maybe, just maybe, Ludmila, can you turn on the microphone? Yeah. I would just like to get the opinion of the colleagues of psychologists specifically about the EMDR. Can it work in this case or not? Thank you so much.
Yeah, I mentioned that EMDR is one of the therapies for PTSD. It is not strongly recommended. It's conditionally recommended because the evidence is not as strong as cognitive behavioral therapy treatment. But it's sort of, it's useful. Some people it's very effective with, and other people it may not be as effective. But it requires special training in order to do it. It's basically reliving the traumatic experiences, but the technique involves using rapid movement. Sorry. Yeah, typical.
Sorry. In this case, I think so. You mentioned it might be harmful because we are forcing them to relive the experience that they had, or what do you mean specifically?
No, we haven't had reports that. I mean, I think there's a concern about re-traumatization anytime you use exposure therapy or prolonged exposure or gradual desensitization techniques. But they have been shown to be effective if done carefully and with good training. So you're not flooding the patient or overly exposing or re-traumatizing them. They have these thoughts and images are coming back to them frequently anyway. They're re-experiencing that, and it's the mind's way of trying to heal, actually, to re-experience those traumas and integrate them into it. But the technique, the exposure therapies and the EMDR are carefully titrated and gradually increased over time, and they are associated with these eye movements that change the way the patient remembers the trauma, makes it integrated more into their lived experience. But I encourage that you should, if you use these techniques, you should get additional training so that you're careful not to cause any re-traumatization.
Can I comment on that as well? I was curious because this is a veteran who's living in a situation where there's still active war. And I think that just adds a layer of extreme complexity. And I think, when thinking about EMDR anecdotally, I spent 5 years working as a psychiatrist with time at a veterans hospital in the United States with veterans either from, 1 year after service up to 30 years after service. And I would say anecdotally, the EMDRs, I feel like comes a little bit late. If somebody was in a situation where they were still experiencing re-traumatization, I would feel that CBT and figuring out how to kind of stop the automative process and handle trauma as it comes might still be the priority.
I would agree with you there. And by the way, I should mention that Dr. Jackson is boarded both in palliative care and psychiatry. So he's an expert for us on these topics as well. Good. All right, let's continue with additional questions. Thank you for those.
I just wanted to mention, and I put it in the chat,
Yeah.
that the comment about buprenorphine, and we sort of facing this a little bit in the US as well, when buprenorphine is known primarily in the formulation of Suboxone that is used for the treatment of substance use disorders. But many people forget that it actually was developed as an analgesic, and it is a potent analgesic that can be definitely used for pain. And I think as Ukraine is facing all the soldiers coming to combat, many with whom will have pain, this will become very important, I think, to consider advocating for allowing buprenorphine to be used as an analgesic for the treatment of pain. I think it will be crucial. Otherwise, you are at risk. If you, it's actually oftentimes even our insurance companies will deny buprenorphine for cancer patients and ask us to use traditional opioids first, which clearly is not the right way to go. And I think with traditional opiates, of course, the risk of substance use disorder and dependence are much higher, especially with long-term use. So I think, advocating for the use of buprenorphine, I think it will be a crucial element of your efforts. And there is a growing, not a lot, but there's growing evidence of the use of buprenorphine for pain. So just wanted to say that. Thank you.
Yeah, I think that's an issue, Alexander, for the association to pay attention to. I know, and historically, there used to be a rule that in Ukraine you could not have more than 50 milligrams per day of morphine, and that limit was taken away because it was inadequate for so many patients who didn't provide adequate analgesia. So I think working together, I agree entirely with Dr. Marson that that there should be an effort to try to change. These are all based on the Soviet healthcare system. That's where this came from, really, and it's not up to date in terms of medical science. Good. Alexander, other questions in the chat that we can address?
Yes, we do have. And a lot of them. And the last question from Natalia Kobal, or the last from her, are people get used to buprenorphine? Like, they get independent, but they're also common. So I guess we ask for the question first. Are people getting used to or getting addicted to buprenorphine, or the dosage stop using or something like that?
So the buprenorphine is as I mentioned, a lot safer than the traditional opioids. The risk of developing opioid tolerance is also less with buprenorphine compared to others. What we notice in our practice is that patients who are placed on buprenorphine oftentimes do not require as much of dose titration as those who are on things like morphine or oxycodone or other opioids. I think that is a medicine that is a lot safer, causes less of the other opioid effects, like the psychomimetic opioid effects that the traditional opioids can. So I think, again, it's this patient and many others, I'm sure, will require medicines other than the non-opioid medications, right? Because their pain is so severe. And again, this is something that you don't have to consider necessarily for the rest of his life. I think right now this is important because he's going through multiple treatments, rehabilitation, etc. Once his condition improves and stabilizes, there should be always effort to see if he still truly needs it. And then gradual, not obviously sudden discontinuation, but a gradual taper. It's possible, and actually with buprenorphine, much easier. So when you're discontinuing buprenorphine, there's also evidence that the withdrawal symptoms are much milder, if any. So if it's done correctly, it can be safely and effectively discontinued over a period of time. So again, I think there is really very hard to argue, I think, about the benefits of buprenorphine in those kind of patients over long term. I hope that helps.
Yeah, I think that would help us make the advocacy case for allowing the use of it as an analgesic. It's partial agonist as an opioid, so you really aren't going to see the sort of psychoactive effects as much in buprenorphine than in morphine and others. Though I know from personal experience that pain is the perfect antidote for opioids. And very little, psychoactive effect when someone's got significant pain. They're just getting pain relief, not getting high, if you will. So anyway, yeah, buprenorphine offers a lot of advantages, particularly for this population. So definitely it's something worth advocating for your patients. Alexander?
Так, тут я
Right.
читаю
I'm just reading out for comments and I see that Natalia Koval is commenting or proposing or giving proposals essentially. Natalia, if it's possible, can you turn on the microphone so that we can have it in full? Because you put a few messages in the beginning, in the middle, and at the end of the chat because you had interesting things to say, but like it's all like in different places and maybe people are not. If you're technically capable of turning on the microphone, please do so. Natalia. And also, I would kindly ask from Hanna Misko if she's able to turn on the microphone and just go a bit into detail, like what specifically you're proposing, because you're also wrote it down. And yes, greetings to you. This is Hanna Misko, and I would just like to express an opinion that for such a patient, you would need to talk to a person to whom this person trusts and to the opinion of which they can listen to. Maybe this is like if he doesn't have his own family, maybe this is his family, or if it's just his wife that he's, I guess, divorced or anything, maybe there's like a friend or a female friend that they might be able to talk to, or like a friend maybe can help them a sense in life or like to try to achieve something or to find like at least some kind of instruments or interest in like a hobby, or to just try to work on something or to have a remote line of work, or like this is the lines of opinions and ideas that I had. Thank you.
Yeah, I think that's certainly a great point. And particularly if it's other veterans, that can relate and communicate and share feelings, and having gone through similar things with injury. Do we have other questions, Alexander? I do want to make a couple of quick comments at the end, just as a wrap up. We have about 3 minutes left, or 5 or 8 minutes if we
Питань
go.
немає. Питань
No,
немає.
we don't really have any other questions. I would just also have like a few proposals, essentially.
Дуже я коротко скажу,
I would just like to shortly mention here that I would just really like to ask if I think maybe Svetlana can tell us right away or at this time, and if not, then maybe like just a bit later we would be able to discuss this. But like, what is the objective and the target? What is the life goal of this person, of this injured person? So what am I alluding to? And maybe, just maybe, this person could have helped with his experience to others, right? Or to other people that are unfortunately in that precondition. And so by helping others, maybe would be for that person his life goal. Like, do you see that, or is it not there yet? Or, and the second issue is that, and also for many years I work in the hospital in Ahmadid for 12 years. There's only one advice that I could have given. Maybe it's not going to be popular for doctors or for the administrators of healthcare system, but yet again, this is just like an advice. Please cooperate more tightly with NGOs or other organizations to support, like veteran organization, or with different like organizations that of peer-to-peer organization and others. So I guess because what I've heard that he had like one consultant, second consultant, third consultant, and all that. But like if that person, he would have like more tighter cooperation with the NGO, or it was a charity organization, with public organization, just maybe it would have been better. And so this is would have been more useful. But there's also like a question here for that. We did a few things in this area of work. can't be, we'll just say that way, he can't be an initiator of the group support, but we are trying with the psychotherapist that is not working in our hospital, but he's working in Cherkasy. We applied for a small grant when as an organization of group support for people that have been through war, and we would be also joining him in as a participant so he can get there like at least some kind of support from participants that maybe they were able to rehabilitate or to stand their ground so that they would give him a stimuli for him to be able to find himself in this line of life or in his new predicament essentially of the life so that he could find like initiation or support or stimuli and for everything to be good. So now it's just like a draft project and all that. Thank you so much. Can I also have it's just moving so fast and intensive because there's just like 5 minutes that we have. From Natalia Rabchinyuk, there's a question. Can dexamethasone or DEXA reduce the headache in this kind of head trauma? The answer is no. We tried and it didn't help.
Alexander, I have a question for Svetlana. Does Svetlana Hospital, does her institution have access to the pain medication that was discussed here?
У нас є метадон, але він іде
We do have methadone, but it's just going on the replacement therapy. We don't have a legal right to use it for any other purpose than to OST or opioid substitution therapy.
Yeah, that's where the advocacy would come in to try to change the rules to allow off-label use or to add that to the label. Okay. Let me make just one kind of large comment about the appropriateness for palliative care for patients with war injuries. And this is a gray area for us, and you're going to be helpful in helping make it less gray, I think. Traditionally, we've had injured patients fall into several different categories. Those who have been injured who will recover, relatively easily from their injuries and, can then receive rehabilitation if needed and go on back to full functioning in their normal life. Then we have kind of middle group that is pretty significant, where these injuries will result in ongoing disability and their ability to function in daily life, but their prognosis remains pretty long and uncertain. And then you have another group, the third group, which are people who are so severely injured that they're not likely to survive long with their injuries. Obviously, the first group we wouldn't typically have palliative care for. The third group we would certainly want palliative care for. And the middle group is kind of left, and this gentleman is kind of in the middle group as I see it. He certainly has significant disabilities and injuries and complex problems that need attention. And so each country actually decides for itself, where to put those boundaries in terms of who's appropriate for palliative care and who isn't. So there's no set rule. In many countries, people with long-term disabilities do continue to receive palliative care, maybe less intensely than someone nearer to the end of life. But I just raised the issue as you find your way here in terms of figuring out triage, if you will, because there's so many of these patients who you're going to, put your efforts toward in terms of palliative care. So just want to put that out there so you can be thinking about it in terms of your journey as you're working, toward helping these people get the care they need. We're down to about 1 minute left. So any other comments or questions? Any closing comments from the experts on the panel or the attendees for the session?
Можна я прочитаю
Can I read out a bit? So Anna Protsenko, the one that mentioned before a few times, and she just can't voice it out. In my practice, I set up in the beginning the absent level of trust. So it's not going to be there. So just because visiting there, so I got him like amulets, fruits, and how the patient feels. So this was just the simple support. It's not nothing major. And so this was like in a period of time this had happened. But like, and within some time, this patient started to trust a bit more, started to open up a bit more, and he did not say no from working with a psychologist.
Well, I think we've now run out of time. Thank you, Alexander. But if we could, I just would like to express our thanks to colleagues in Ukraine for the work you're doing and our desire to continue to provide support as much as we can. We hope to increase the support. Right now, we're doing this work without funding, so except for some small funds that are coming in from Global Giving. But we will be back together, I think, Alexander, in January for the next in this series of case conferences, and we'll be letting you know the dates and the details about that. Any other comments before we close? Thank you again, Dr. Svetlana, for this very, very interesting case and very important for the future of palliative care. Thank you so much.
Thank you,
And thanks for coming.
Я дуже вдячна
Thank
вам
you
за
so
підтримку,
much
за
for the
допомогу.
support, for being here, for participating, and for just being there to support us. It means a lot.
Ну, тоді ми будемо закінчувати. Запис
So I guess then we can
він
finish.
буде
We will have a recording.
записаний, не переживайте.
It will be sent, so don't worry. So everybody's gonna have, if somebody did not hear something, somebody missed something, it's just gonna be there waiting for you.
Ну, тоді
Okay,
все.
then
Take care.
that's it, I guess. Thank you so much.
Bye.
Bye-bye.
До побачення.
До побачення.
До побачення.
Good